Hi, my name is Szilard Voros. I am a cardiologist, and I have been studying lipids, lipoproteins, and cardiovascular disease for over 25 years now. Today, I would like to speak with you about one item, and I would like to remind you that you should be measuring Lp(a) cholesterol in addition to total measurements of Lp(a), such as molar concentration or particle number or Lp(a) mass, because Lp(a) cholesterol measurements carry additional, incremental, and independent information about cardiovascular risk. Lp(a) is the most prevalent form of genetically determined cardiovascular disease today. Lp(a) is like a Trojan horse. The wooden horse itself is the Lp(a) particle, if you will, and the soldiers hiding inside the horse are the cholesterol molecules. You can think about the wooden horse as the Lp(a) particle containing the ApoB protein itself, and the tail of the horse is the apolityl protein, the apolityl moiety. Some horses have very short tails. Those are the really dangerous ones. The small isoforms of Lp(a) are most atherogenic. Some horses have longer tails. These are the larger isoforms of Lp(a) that are less atherogenic. When you are measuring total measurements of Lp(a), molar concentration or particle number or Lpa mass, you are counting the total number of horses. When, on the other hand, you measure Lp(a) cholesterol, you're counting how many soldiers are hiding on the inside. If you really need to know just how much danger you're in, you need to know how many horses did the enemy send inside your blood vessels, what are the total measurements of Lp(a), and you also need to know how many soldiers are hiding on the inside. What are the Lp(a) cholesterol measurements? We have been doing research on Lp(a) for over 2 decades, and I would like to share with you 4 important observations. First, we know that in general, Lp(a) measurements carry independent and incremental risk information on top of ApoB. What that means from a practical perspective, that if you have a patient with about 100 ApoB particles, if out of those 100 ApoB particles, 5 are atherogenic Lp(a) particles, that patient is a significantly higher risk than another patient with 100 ApoB particles, yet only 2 of them being Lp(a) particles. The second observation is that when you look at the likelihood of having a plaque in the coronary arteries, in patients with elevated Lp(a) cholesterol, there is a 70% increased risk of having a plaque, whereas in patients with elevated molar concentrations of Lp(a), that risk is only increased by 30%, and those with an elevated Lp(a) mass, that likelihood is only increased by 40%. Now, the third observation is that when we look at the different types of plaques within the coronary arteries using cardiac CT, for example, we found that Lp(a) cholesterol is very significantly higher in patients with so-called partially calcified plaques. And partially calcified plaques are known to have the highest risk of developing into myocardial infarction. And patients with partially calcified plaques has significantly higher levels of Lp(a) cholesterol, and this relationship was much stronger than the relationship to molar concentration or particle number or Lp(a) mass. And finally, the fourth observation is that patients who already had a myocardial infarction, those had, again, significantly elevated Lp(a) cholesterol levels compared to those patients who have not had a myocardial infarction. So finally, why do we care about Lp(a) levels? And really there are 3 main reasons. The first one is that in patients with elevated Lp(a), we will be much more aggressive about general lifestyle modifications. The second reason is that in patients with elevated Lp(a), we will be very aggressive about lowering LDL cholesterol levels with every tool we have. And thirdly, now there are ongoing phase 2 and phase 3 clinical trials of brand new novel therapies that actually specifically and drastically and dramatically can lower Lp(a) concentrations. And if those clinical studies prove to be positive, we will, for the first time, have novel treatments to lower Lp(a) in patients who have high risk. So remember, in order to understand the full risk profile associated with Lp(a), it's not enough to test total measurements of Lp(a), such as molar concentration or particle number or Lp(a) mass. We also have to test Lp(a) cholesterol to understand the full picture of risk.